Chapter 4. Steps of the all-natural breast reconstruction process and how to optimize each one. Breast reconstruction is a process, and the steps in this process can be divided into before, during, and after surgery. Before surgery. Whether you have had the total mastectomy or not, you will meet with the reconstructive plastic surgeon, and there will be a thorough evaluation where you will give the chance to tell your story and to share your goals for what you'd like to achieve. The surgeon will perform a thorough history and physical and will give a comprehensive list of the options with the advantages and disadvantages of each. Additionally, you will often meet with a pre-surgical testing team comprised of medical doctors or anesthesiologists who will also perform a thorough medical evaluation, check some blood tests, and if necessary, arrange for you to also see the relevant specialists, such as lung specialists, heart specialists, etc. If you are to undergo reconstruction at the same time as your mastectomy, all of this will be done in conjunction with your breast surgery team. If you are to undergo reconstruction months or even years after the mastectomy has been performed, those teams will be informed of the upcoming reconstruction procedure and their input will be sought, but it is unlikely that they will be directly involved. Your surgeon will advise you about which of your medications to continue taking, which will most likely be most of them, and which you will be suggested to not take, usually things such as blood thinning medications. Your surgeon's office and the operating room nurses usually inform you the day before surgery about the exact time and location for you to arrive. And in almost all cases, you will be asked to not have anything to eat or drink beginning at midnight of the night before surgery. Though most things that you'll need will be provided for you, it's a good idea to pack at least a few things. It'll be helpful to ask your surgical team their recommendations about how many nights you will likely stay in the hospital, if any, and what they suggest that you bring with you. For women who are not scheduled to stay overnight, we recommend that they bring their ID card and insurance cards, comfortable loose clothing such as sweatpants, your cell phone and a charger, a book or magazine, and your glasses if you wear contacts. For women who are scheduled to stay at least one night in the hospital, it is generally a good idea to bring all of the same things above, as well as your own pajamas and a blanket. Make sure to set an alarm or two the night before, because you will likely be asked to arrive at the hospital or outpatient surgery center somewhat early in the morning. And while it is very common to be nervous, try your best to get some sleep that night. Day of surgery. You will be asked to arrive a few hours before the scheduled start time. You'll be checked in by the admitting team. You will review with them your insurance information and other paperwork, and then you will go to the preoperative area to meet with the nursing team. These nurses will help you change out of your clothes and into a preoperative gown, safely stow your belongings, and advise you of what to expect for the remainder of the time before the operation. You'll meet with the anesthesiologist assigned to your operation, and you'll meet with the surgical team or teams, depending on whether the breast surgery team is involved in the operation that day. Your surgeon will review the planned operation and the postoperative instructions, answer any questions that you have, confirm the consent form for the procedure, and finalize the plans for the operation by doing the markings directly on your body. This marking process is often one of the most important parts of the entire operation, because your surgeon will be able to evaluate the exact appearance of the surgical site, usually while you're standing in an upright position, and will be able to measure exact dimensions. Your surgeon will identify areas of even slight asymmetry between left and right sides. By noting this asymmetry, he or she will be able to take that into consideration and hopefully counteract that asymmetry, and in the end, leave things as symmetrical as possible. Though remember that perfectly exact symmetry is never actually achieved, despite our best attempts at doing so. For women who are undergoing the initial all-natural breast reconstruction procedure, where the tissue is moved from one part of the body to the chest, such as the DIEP flap procedure, the operation will likely take between 4 and 6 hours if one side, or 6 to 8 hours if two sides. If it is a subsequent revision procedure such as fat grafting or scar revision, it will usually take approximately 1 to 2 hours. Once you're inside the operating room, an IV will be placed, and within a few minutes you will be asleep. After you are asleep, the breathing tube is placed, more preparations are done by the anesthesiologist, and then the procedure is performed. Though there is much detail and nuance to each type of all-natural breast reconstruction procedure, The simple description is that the tissue that is going to be used to create the reconstructed breast is carefully collected from the donor site, most commonly the abdominal wall, thighs, or buttock. The chest is prepared by shaping the pocket and exposing the blood vessels. The blood vessels are connected, and then the donor site and the reconstructed breast are closed in a way that makes each site as healthy and natural looking as possible. The breathing tube will be removed before you are awakened from anesthesia. At that point, you are then fully awakened, and then you are moved from the operating room to the recovery room, often referred to as the PACU, which stands for Post-Anesthesia Care Unit. Once in the PACU, in conjunction with your anesthesia and surgical teams, you will be cared for by members of the PACU nursing team who specialize in monitoring people immediately after surgery. These nurses will ensure that your pain is well controlled and that the surgical sites continue to be healthy, and they will teach you more about what to watch for and how to perform any necessary drain care or wound care. Depending on the type of operation, you're usually in the PACU for a few hours, and then you are either transferred home or to your room in the hospital. Recovery in the hospital, 1 to 3 days. If you have undergone a newly placed free tissue transfer procedure, such as the DIEP flap, this will mark the beginning of the flap monitoring that will occur very frequently during the first few days after your operation. There's almost always at least a small patch of skin, and sometimes a big patch of skin if needed, that remains connected to the fat that is used to provide the volume and shape for the reconstructed breast. That skin serves the incredibly important role of showing whether the blood flow to the tissue has been in any way interrupted. Your doctors and nurses will monitor this patch of skin closely for its color and for the sound of the blood flow using a Doppler, like an ultrasound that gives a sound. In some cases, there are different sorts of probes that can be more directly monitor the blood flow and will indicate if there is any change. Fortunately, the likelihood of blood flow changes in all-natural breast reconstruction is very low, usually about 1%. But if it does happen, it is important that your surgical team know about it right away so that the tissue has the best chance of being saved by a return trip to the operating room. Assuming that the blood flow is continuing without any changes, your active participation in the recovery process often begins the morning of the first day after surgery. It is over the course of this day that you will be asked to increase your activity levels and your mobility. Your surgeon will give you specific instructions, but in most cases you will first sit in a chair and then walk during that first day, and you will be asked to gradually move towards regular and unrestricted movements of your arms and shoulders. Physical therapists are a key part of the recovery process, and their active involvement starting from the first day in the hospital is very helpful. You will almost certainly have at least a few surgical drains placed during your operation, at least one in each breast that has been operated upon, and at least one in the donor site where the tissue was collected from, abdomen, thighs, etc. These drains serve the important role of allowing fluid to be evacuated from the surgical site, instead of accumulating and causing a fluid collection that can derail what would otherwise be a smooth recovery. You will be taught how to care for these drains, and they are usually removed painlessly after 1 to 2 weeks. If your surgical team does not provide you with a complete drain management program, one can be found at www.hendersonbreastreconstruction.com/drains. Recovery at home. Once you have met the criteria for being able to transition to home, there are many ways that you can help to facilitate your ongoing recovery. Either with the assistance of a physical therapist, or on your own with guidance from your surgical team, you are encouraged to participate in stretching and range of motion exercises. Though strenuous and vigorous exercise is to be avoided for at least the first month after surgery. Assuming that you have been discharged home with at least one surgical drain still in place, you will be asked to continue to periodically empty and record the amount that was drained. You will likely have been prescribed some combination of pain medicine, antibiotics, and blood thinning medicines, and are encouraged to take them on the prescribed schedule. In most cases, your reconstructive surgeon will see you in the office setting each week for the first 2 to 3 weeks, then less frequently after that. Some women are surprised by this, but if they have immediate reconstruction at the same time as the mastectomy, they will often have a relatively small number of spaced out postoperative visits with their breast surgeon, but much more frequent visits with the reconstructive surgeon. Starting at about 1 to 2 months, most women are recommended to fully resume all activities, even strenuous activities. But it usually takes a few more months after that until women find that their activity levels have achieved a totally unrestricted level. Secondary procedures. As our team frequently reminds women, breast reconstruction is a process and not a single event. As such, there are often optional secondary surgical procedures that are often eagerly consented to because they can be a very beneficial icing on the cake to complete the reconstructive process. The first technique is liposuction. If the reconstructed breast turns out to be a little bigger than is desired, it is relatively easy to reduce its size. This excess fat can most commonly be removed by liposuction. This procedure is performed in an operating room under general anesthesia and works by first injecting some fluid into the reconstructed breast. Then the liposuction cannula, which is like a long, thin vacuum wand, is inserted through a 1/4-inch incision and then passed back and forth many times, each time collecting some of the fluid that has been injected, as well as some fat. When done carefully and artistically, the amount and location of fat removed can lead to a breast that has the desired shape. The second technique is fat injections. Sometimes referred to as fat grafting or fat transfer, this technique can be used to slightly increase the size of the reconstructed breast or to address small contour irregularities. As opposed to traditional fat-based all-natural breast reconstruction procedures such as the DIEP flap, where the fat is moved as one continuous piece, in fat injections, the fat is collected by liposuction, sterilely loaded into a syringe, and then injected into the area of interest. This is a powerful technique, but it is limited to being able to only safely transfer relatively small amounts of fat at any one given time. The good news is that if more fat is desired than can be transferred in one session, it can be performed multiple times to the same site, as long as 3 months are allowed to pass between sessions. Liposuction is performed in a manner similar to what was described above, but instead of injecting the fluid into the breast, the fluid is injected into the site where the fat will be collected from, which is usually the front of the abdomen, the flanks, the inner thighs, or the lower back, but in theory could be from anywhere on the body. The liposuction cannula is used in a similar manner, but instead of the fat being discarded, it is sterilely collected and then put into syringes. The fat is then injected through a small needle back into the area of interest. Most of the fat that is injected, usually about 2/3, then successfully takes root and stays there forever. The third is donor site revisions. Whether the tissue is taken from the abdomen or the thighs or the buttocks, it is not uncommon for there to be at least some small asymmetry. Fortunately, by surgically removing any unsightly scar and then doing some form of debulking or shape contouring, the donor site often can have a very pleasing appearance. The fourth is reconstruction of the nipple and areola, if they were removed in the course of the mastectomy. Some women choose to never have it performed, and that is of course totally fine, but many women do choose to do so. Nipple reconstruction is a small procedure that can have a huge effect. It is often performed in the office setting using local anesthesia, but the magnitude of the effect and how far it goes towards pushing the woman across the finish line is significant. As with all phases of the all-natural breast reconstruction process, there are many different techniques that can be used, and of course each procedure is always tailored to each woman's unique goals and circumstances. But in general, nipple reconstruction can be performed using tattoo only, surgical reconstruction plus tattoo, or nipple sharing plus tattoo. In tattoo only, a specialist, either the reconstructive surgeon, a member of the surgeon's team, or an outside tattoo artist, utilizes tattoo pigment and tattoo equipment in order to provide not only the color of the areola, but also three-dimensional shading and coloring that gives the appearance of a nipple that projects forward. In surgical reconstruction plus tattoo, a clever type of origami is performed where a small amount of skin directly at the intended site of nipple reconstruction is partially incised, folded on itself, and stitched together. The end result is a three-dimensional structure that has the appearance of a nipple. Of note, these reconstructed nipples have a notorious tendency to decrease in projection over time, sometimes up to 50%. So your surgeon will often attempt to oversize it at first, so that when it inevitably becomes smaller, it ends at a size that closely matches the other side. Because the surgically reconstructed nipple will have the same color as the reconstructed breast skin, once it has healed, the same tattoo technique can be performed in order to provide color to both the nipple itself and a circle of surrounding skin in order to simulate the appearance of the areola. But as opposed to the tattoo-only technique, shading will not be necessary because true three-dimensional structure has already been created. But some specialists do still attempt shading even when the structure has been created, and have sometimes referred to this technique as 4D nipple reconstruction. Finally, there's a different sort of technique that is not for everyone, but when the situation is just right, it is a particularly great way of doing it. This is referred to as nipple sharing. If a woman has had a total mastectomy on one side that has removed the nipple, and if the intact nipple on the other side is either large or very large, half of the remaining nipple can be removed and transplanted to the side in need of reconstruction. Of course, this results in a reduction of size of the intact nipple. If it started small or even medium size, it would likely be too small after half had been removed to the other side, and therefore it is not a good option for that woman. But if the nipple begins as large, or especially if it is very large, then after partial removal, it will only be half as large, which those women often find tolerable, if not actually preferable, and the reconstructed breast will have a nipple that is not only a good size, but also a perfect color and texture match. After it has healed, the same tattoo equipment can be used to provide color that simulates the areola. The fifth is reshaping of the other breast. Depending on the size, shape, and position of the reconstructed breast, and each woman's individual goals, there may be a role for performing a procedure on the other breast. If the size of the other breast is appropriate, but it needs to be lifted, a breast lift, mastectomy, can be performed. If the other breast is too big, a breast reduction can be performed. And if the other breast is not big enough, its size can be increased by either fat injections or even placement of a breast implant. So, as you can see, there are many advantages to all natural breast reconstruction. But as with anything in surgery and anything in life, there are complications that can occur. In the next chapter, we'll discuss what those are, what to watch for, and most importantly, what you can do to reduce the chance that any of them happen to you.